We are going to go ahead and get started.
Good morning, everyone. Welcome to Workshop 24, Nutrition Modulators, Modulators and Nutrition. My name is Sherry Willie. I am a registered dietitian and program coordinator at the University of Louisville in Louisville, Kentucky. My co-chair for today is Jessica Alvarez, and she comes from Emory University in Atlanta, Georgia. Here are our disclosures for this session. And just some session tips. We will include 5 research study abstracts related to CFTR modulators and their impact on nutrition outcomes. We will host question and answer time after each speaker. Please submit questions during the presentation via the audience engagement tool found in the NACFC app or by live speaking clearly into the microphone after each presentation. And we do ask to minimize distractions. Please silence all mobile devices, tablets, and computers, or anything else that may make a ring and ding noise. Our first speaker today is Dr. Nicole Green. She is speaking on the impact of Elexacaftor, Tezacaftor, Ivacaftor on gastrointestinal outcomes, inflammation, exocrine pancreatic function, and fat malabsorption, a report out of the PROMISE study. And Dr. Green is joining us from Seattle Children's Hospital, where she is a pediatric gastroenterologist. Dr. Green?
Good morning, and thank you to the NACFC organizers and Jessica and Sherry for inviting me to speak today. I am presenting the impact of Elexacaftor, Tezacaftor, Ivacaftor on gastrointestinal outcomes, inflammation, exocrine pancreatic function, and fat malabsorption. And this is a report from the PROMISE Peds GI study. I have no relationships to disclose related to this presentation. So in terms of background, as many of us already know, gastrointestinal disease is a central feature of cystic fibrosis, and it represents a significant source of morbidity for this population. The image on the right is just demonstrating how extensive CF symptoms and disease is within this population. So in terms of hepatobiliary disease, gastrointestinal luminal disease, as well as we well know, the pancreas. CFTR is expressed throughout the gastrointestinal system. So there is high expression in the small bowel, especially the duodenum, and expression decreases as you move through the small intestine towards the ileum. The colon has moderate expression of CFTR. The pancreas has high expression, especially in the small intercalated ducts. In terms of the hepatobiliary system, CFTR is expressed in the bile ducts, but not the hepatocytes. And then we know that CFTR is also present in the submucosal and myenteric plexuses. So CFTR is expressed on the apical surface of epithelial cells in these organs, so the pancreas, intestines, and hepatobiliary tree. When CFTR is mutated, you get disruption of epithelial cell iron and water permeability. You get reduced bicarbonate secretion, so as a result, you get a more acidic small intestinal environment and thick viscous secretions in these organs. We think this most likely contributes to the inflammation, dysmotility, dysbiosis, and GI symptoms that are well described in this population. This slide is just to demonstrate GI symptoms that have been described in the CF population. So this was a survey of 130 adults and pediatrics, asking them about their GI issues. And as you can see, high complaints in terms of disorders of eating and appetite and lack of appetite, as well as pain symptoms and flatulence and abdominal distension. Moving on to Elexacaftor, Tezacaftor, Ivacaftor, or ETI. This is a CFTR corrector potentiator and is now approved for people with CF greater than or equal to 2 years of age with at least one ETI-responsive CFTR allele. We know that CFTR modulators have demonstrated pulmonary benefit, but their effect on the GI outcomes, intestinal inflammation, and pancreatic function is less clear. So PROMISE GI was an observational study of ETI in people with CF greater than or equal to 12 years with at least one F508del allele. This study demonstrated no clinically important changes in GI symptoms, a reduction in intestinal inflammation, and no change in fecal elastase. PROMISE PEDS, which is what I will be presenting here, was to assess the efficacy of ETI in children with CF ages 6 to 11. Specifically, the GI sub-study was assessing GI symptoms measured by patient report outcome measures and collection of fecal biomarkers. This was an observational prospective cohort study at 20 US centers in the CFF TDN. As stated, we enrolled patients aged 6 to 11 at ETI initiation with at least one F508del allele and collected patient-reported outcome measures and fecal biomarkers. All patients in the study served as their own controls, and the results that I'll present today are the baseline 1, 6, and 12-month changes for the patient-reported outcome measures, as well as the baseline 1 and 6-month fecal biomarkers. And these results are all adjusted for sex at birth and prior modulator use. So in terms of symptom assessment, collected the PAGI-SIM, which is a patient assessment of gastrointestinal disorders symptom severity index, PAC-SIM, a patient assessment of constipation symptoms, PAC-Q of L, patient assessment of constipation symptoms and quality of life, and the Bristol Stool Scale and Stool Frequency Questionnaire. Fecal biomarkers included a calprotectin, fecal calprotectin, which is a measure of intestinal inflammation, steatocrit, which is a measure of stool fat content, and a pancreatic elastase, which is a measure of exocrine pancreatic function. This table demonstrates demographic data at baseline. So mean age was 9 years. There was 57% were male, 96% were white, and 38% were modulator naive. These are the patient-reported outcome measure completion rates at baseline and through 12 months. So by 12 months, we had a 67% completion rate for these surveys. So starting with the PAGI-SIM, this is the assessment of gastrointestinal disorders symptom severity index, and it's divided into 6 domains. So nausea, vomiting, postprandial fullness, bloating, upper abdominal pain, lower abdominal pain, and reflux. A score of 0 means absent, and a score of 5 is very severe. And you can see that overall, we did see some decrease in the postprandial fullness and bloating over the 12-month of the study period, but the total score changes were not significant. PAC-SIM, the patient assessment of constipation symptoms, no significant changes. PAC-Q of L, patient assessment of constipation symptoms related to quality of life, no significant changes. And then finally, for this tool, the Bristol Stool Scale or constipation, we did see a decrease in constipation from 14% at baseline to 2.5% at 12 months of ETI. Moving on to the fecal biomarkers, so starting with fecal calprotectin, which is a measure of intestinal inflammation, there was significant decrease in absolute numbers of fecal calprotectin, but what we were interested in from a clinically relevant perspective was sort of changing from normal, borderline to abnormal rather than just the absolute numbers. And there was a substantial increase in participants with calprotectin in the normal range. So hard to see, it's small, but at baseline, 51% of participants had a normal calprotectin, and by 6 months, 89% had calprotectin in the normal range. Fecal elastase, there was no statistically significant change. And steatocrit, no significant change in steatocrit. So to conclude, overall, there was no significant change in the patient-reported outcome measures, so assessing GI symptoms and quality of life after 12 months on ETI. However, I think it is important to know that this population was not selected in terms of having GI symptoms. Their scores for GI symptoms were low at baseline, so we weren't selecting a group with a large amount of GI complaints. Intestinal inflammation or calprotectin decreased after 6 months on ETI, and we did not find a significant change in fecal elastase or steatocrit. So where do we go from here? There definitely seems to be a trend towards normalization of calprotectin, which reflects improvement in intestinal inflammation. I think this is really exciting in terms of clinical implications. It may improve nutritional status. In terms of GI symptoms, I think it would be interesting to focus perhaps on the patient-reported outcome measures that demonstrated some improvement, such as bloating, to see if this was correlated or could be explained by a decreased inflammation. And then long-term, how this might have an implication on GI malignancies, which we know, especially in other GI diseases, is related to intestinal inflammation, and there is higher rates of GI malignancy in the CF population. In terms of fecal elastase, there have been mixed findings across the modulator studies, and perhaps there might be age-specific effects. Maybe earlier initiation of ETI in younger children with CF could be more likely to restore exocrine pancreatic function, and these are still questions to be explored. So to conclude, I would like to thank and acknowledge, first and foremost, the participants in this study and their families, without whom this would not be possible, as well as the 20 CFF TDN centers enrolled in the PROMISE Peds substudy, as well as the PROMISE GI substudy and PROMISE Peds leaders. And with that, I'll take any questions.
Thank you, Dr. Green. Questions?
Thanks, Nicole. That was a lovely presentation and a really important piece of work. I want to ask you about the symptom scores and what your thoughts are on those, because we have a highly effective modulator which has shown dramatic effects on pulmonary function and exacerbations, but the effects on gut symptoms appear to be modest, if any.
Yeah.
And I guess the calprotectin data are really interesting. So there's a drop in calprotectin, but if you compare people with CF, their calprotectin levels with, let's say, inflammatory bowel disease, in inflammatory bowel disease, it's another level entirely up. So is it that inflammation isn't the most important piece of the picture, or is it that the tools that we're using to measure symptoms are not really up to the job?
Yeah, personally, I don't think that the pain and symptoms are fully driven by inflammation or significantly driven by inflammation in many with CF. I think, there's definitely perhaps motility could be playing a factor, especially sort of the bloating symptoms. So yeah, I don't know if inflammation is really necessarily the driver of the pain symptoms. And then, as you can see, these pain scores were really low at, symptom scores were really low at baseline for this group. So 0 is absent. So I think maybe selecting for a population who have more GI complaints might be more revealing. So thanks.
Zach Seller, Stanford. Nicole, great talk. Do you have any data on the diets for these individuals, and could some of the changes in bloating and abdominal fullness be reflected by changes in the diets and the amount of calories we're giving these individuals as their weights have improved? So are we not doing as much, pushing as much of the calories and the amount of food and formula we're putting in, and so as a result, they feel less full and maybe have some less bloating?
Yeah, thanks for that question. We don't have that collected in terms of dietary history for the PROMISE Peds, but I think that is very interesting to explore in diet. Obviously, we're at a nutrition workshop, and I think, we have seen weight gain, and I think either patients themselves are changing their dietary practices as they see weight gain, and recommendations are also changing. So I think that could definitely be playing a role here in the changes in symptoms.
Thank you.
Hey, Jay Freeman from Nationwide Children's. Nicole, it's a lot of data. Well done. You summarized it very well. So kind of eyeballing from what the levels you have up there, they look very similar to what we had in Galaxy as far as, kind of those low values. But we did have about a third of our patients with moderate to severe. And that's when we started doing some of our analysis, trying to get secondary diagnosis or definitions for constipation. We kind of focused on that third of the group. Did you see that as well, where you had a subset that did have more severe disease, and were you able to evaluate them separately from the rest of the group?
Yeah, we didn't pull those out, but I think, we have to look at numbers. It wasn't a lot with the severe, so I don't know if we'll be able to make any calls on sort of significance when we control for everything else, but I think future studies, should really highlight those more severe.
Yeah. And obviously, Steve and Sarah Jane know this, and they know that talk. The other thing, because there's nobody else, just to let you know, I don't know if Meg Sauté is in the room or not, but we just submitted a paper to look at minimal clinical change difference of these subsets that are going to be CF specific. So hopefully that will help us interpret this data and know what a meaningful change is in a patient with CF instead of using the functional abdominal thresholds that are currently used. So hopefully more to come with that.
That would be great. Thank you.
We do have one question from the app, and you did touch on it a bit with the second response you gave. But the question was, any notable weight gain during the 6 months on ETI?
Yes, there was weight gain for this population. Thank you. Okay. All right. Thank you
so much.
Thank you.
Okay, next we've got Dr. Julie Sanville from Dartmouth Medical Center, and she'll be presenting on pre-modulator microbiome alterations associated with post-modulator growth outcomes in pediatric CF. Can we predict outcomes?
Hi, everybody. Thank you so much for having me to NACFC and the moderators. It's a great session you've put together. So I'd love to talk with you about my study, Pre-Modulator Microbiome Associations Associated with Post-Modulator Growth Outcomes in Pediatric CF. Can we predict outcomes? I have no disclosures related to this talk. So a little bit of background for you. So studies have shown us that the gut microbiome plays an important role in childhood growth and is influenced by a variety of factors. It plays a critical role in metabolism and immune system training, and we now understand that a typical child's microbiome evolves through a series of phases, and disruptions in those patterns may result in a variety of health outcomes. This figure is from the TEDdy study, which actually looked at environmental determinants of diabetes in the young, but it was able to create a robust dearth of analysis of pediatric microbiome data that they were able to clearly show transitions in clusters of different microbiome organization and a differential abundant taxa from different phases to developmental phase early on to transitional phase, and then a more stable phase as the child ages. So the Dartmouth Cystic Fibrosis Infant and Child Cohort Study was actually started in 2009 by Dr. Juliette Medan and is designed to analyze the longitudinal microbiome and metabolome of children with CF early in life to understand relationships between early perturbations in the microbiome and CF-related disease progression, as well as long-term health outcomes. So we've been collecting samples and data and poop samples on our children for a long time now, and I just want to acknowledge that the group of women doing the bulk of that work, the dirty work, is actually in the audience today, so I wanted to thank them for all of that work. So previous work from our cohort has demonstrated that the CF microbiome is very different from healthy controls, that the gut microbiome presages the respiratory microbiome and its development, is influenced by exposures such as nutrition and antibiotics, and is also related to health outcomes. So I'm not going to get too much into the weeds about all of this. This is a clinical session, but just a quick outline to show you that some of the more obvious differential abundance in key microbiome taxa are just obvious when you compare CF kids to control kids. So now, we've been doing this for years. We have all of this great early childhood data in our kids with CF, and can we now use this data for any predictive capabilities? So especially in the setting of highly effective modulator therapy, we are clearly seeing improvements in children with CF in their BMI, which we also know correlates with lung function. However, we are seeing now with modulator therapy that once you're at the 50th percentile, you get no more benefit from a higher BMI. Thus, we need to work to mitigate further gains and avoid additional comorbidities of obesity. It's interesting, I've been in CF for 5 years now, and for me coming in as a new person to be talking to our CF patients and families about how to adjust their diet because we're worried about obesity was a weird thing. And I'm sure you guys have heard a lot of that at this conference, but definitely something that we're working on very wholeheartedly. And just those interactions was one of the major nituses for the start of this project in particular. Okay, so HEMT, growth and microbiome. In just a little summary of the background. Childhood microbiome can be predictive. Microbiome is altered in children with CF. BMI increasing overall in the setting of HEMT use, but disparity remains, so it's not everybody and it's not always sustained as we're seeing. Obesity is something we talk about regularly now with our CF patients and families. We have little data on microbiome pre and post modulator therapy in children with CF. And it's unclear whether the altered gut milieu plays a foundational role in determining growth in the setting of our new therapies. So with that, our objective was to elucidate a pre-modulator microbial signature associated with post-modulator suboptimal growth or risk of being overweight for children with CF. So is there a signature in the CF microbiome that can help us predict growth in any meaningful way? And can we intervene to prevent some of these comorbid complications we're now worried about? So our methods. So we had 40 children with CF that have been followed since birth in our study that we've collected samples on periodically, longitudinal from approximately 2 weeks to 60 months. And we recorded demographics and key clinical data. Our study groups were based on BMI or weight for length, depending on the age of the child. And we used Z-scores to determine their nutritional status, which were then categorized accordingly. So we performed whole genome sequencing, and the genome was processed to determine the differential abundant taxa. And microbiome analysis in it is inherently messy, and there's lots of potential factors at play. So what we did was used several models to mitigate those factors to help try and explain those findings and whether they're better than chance. So our results. Here's a table 1 breakdown. I want you to note that there's only 2 categories here, normal weight and risk of overweight. We actually had no undernourished kids in our study, which minimizes my groups, but also I was thrilled to say that we had no undernourished kids in our cohort. So we had a total of 189 stool samples collected longitudinally from the 40 unique subjects with a median of 9 samples for each patient. Most subjects were pancreatic insufficient and on highly effective modulator therapy when growth data was captured for our final analysis. So if we dig into the data a little bit, here in figure 1A, it shows that our study groups in themselves are inherently similar, thus the alpha diversity is low. So the risk of overweight group, they looked like each other, and the normal rate group, they also looked like each other. And figure 1B shows the difference between study groups is statistically significant, and therefore the risk of overweight group is meaningfully different from the normal weight group. So these groups are like each other, but inherently different from one another. And then this is just a quick representation to show you the 3 separate models we used. We're not going to go through these in detail, I promise. But just when we take all of those models and summarize them, we're able to conclude that there is a specific overlap in differential abundant taxa across the models that was statistically significant when we adjusted for age, sex, mutation, antibiotic use, early feeding method, and modulator. So the taxa that were consistently altered across the 3 differential abundance models for the at-risk of overweight group included several taxa that were Ergothella, Ruminococcus, Bacteroides, and Doria. So sort of like a Venn diagram to show the overlap of the modeling to show you that these were the same types of microbes that came out with each analysis. And so if we dig into the specifics about these bugs, we can see that there are some interesting notes about these specific taxa as they're related to chronic disease and obesity. So just a couple of things to note as I reviewed the literature. And then how is this useful? So that's always the question about microbiome data, right? Is how is this going to be useful? Well, if we know there are differences, we can use that to make predictions and mitigate risk. Changing our guidance around the nutrition and lifestyle on the early side. For instance, moving away from high fat, high calorie, which we are now doing, to a more standard, healthy, variable diet is really of significant importance. And so this is the first study to elucidate an early life pre-modulator microbiome signature that may be associated with later growth outcomes, namely the risk of being overweight. And we found that when adjusted for all of the clinical variables we collected. And so let me leave you with this thought, especially for the microbiome skeptics out there. When the first cell phone came out in 1973, did anyone imagine that we would have our whole universe on our cell phones, on our wrists today? So, just thinking about, can you really see the future? And, microbiome may be a part of the future, which is likely personalized medicine once we can truly understand it and be able to use it. So I want to thank my New Hampshire CF Center team, our patients and our families, as well as the foundation, DART CF, and my colleagues who contributed to this work.
Thank you. That was great. I'll start with a question for you.
Sure.
Do you know of, in the literature, of any dietary patterns associated with some of the differentiating bacteria that you saw?
No. But I think that's like the next phase, right? Is like, so if we're finding these differences, can we change the dietary plan or recommendations or track it more closely to try and sort that out a little bit better? As I've sort of become the clinical director of this cohort over the last 2 years or so, I'm working to change the model of data collection that we're doing, and we are going to start to implement some dietary information that hadn't been recorded previously. So, a lot of the data I'm working from is now a fair number of years old, as we're using it as like a predictive model, looking at early microbiome. But as I go forward, we continue to collect samples, and now I'm going to try and correlate that with additional clinical data that will hopefully prove meaningful down the road.
And Dr. Sanville, we have 2 questions from the app. The first is, how did you determine at the start which patients were at risk for overweight?
So we use their BMI Z-scores. And we put them in the categories of kids with the, when you're above standard deviation and you're at that mark where you're not quite considered overweight, but you're just at that Z-score threshold, that 83 percentile, you get concerned that we're headed in the wrong direction. So we based our groups off of the Z-scores for that reason, to be able to predict the risk.
And our next question is, did your taxa align in siblings or geography?
That's interesting. I think geographically, they're all New Hampshire kids. So New Hampshire is pretty homogeneous in a lot of ways. So we're all in a similar geographic location. Siblings, I think we have one set of siblings in the study, and I don't specifically have information about their analysis, but that I could go back and look at that. I do have lots of sub-study analysis. This is what I could present right now. The paper is in its final draft, so we did a lot of subgroup analysis and additional, investigation throughout all the data we have.
Okay. Thank you so much.
Wait, and again,
Okay. Next up, we have Amber James from the University of Virginia, and she will be speaking on analysis of iron status after initiation of ETI.
Thank you. Good morning, and thank you for having me. So my presentation is titled Analysis of Iron Status After Initiation of ETI. Okay, I have no disclosures. So just some background information, iron deficiency is highly prevalent among people living with cystic fibrosis, in part due to exocrine pancreatic insufficiency. The prevalence of iron deficiency has been noted as high as 60% in this population. And so ETI was approved by the FDA in 2019. It has shown widespread clinical improvements in FEV1, sweat chloride, respiratory symptoms, BMI, and the rate of pulmonary exacerbations. And ETI has been used widely among people living with CF. And so our question became, how does ETI impact iron status among this population? So the aim of our study was to investigate iron status after initiation of a CFTR modulator therapy, so ETI, in a real-world cohort of patients living with CF. So our methods, this was a single-center retrospective cohort study of 127 adult CF patients. The lab values we analyzed were iron, ferritin, transferrin, and percent saturation of transferrin. The study period took place between January 2018 to September 2022. So we took lab values 2 years pre and 2 years post ETI initiation. And our primary outcome was looking at laboratory values for iron status post ETI initiation. And then we had two secondary outcomes. So our first was a comparison of lab values for patients on iron supplementation versus those who were not on iron supplementation. And then next, we looked just at the group of patients on iron supplementation, and we compared the lab values for patients who took their iron as prescribed, so people who were using it consistently, versus those who were not taking iron as prescribed or using it inconsistently. And so for our statistical analysis, we used 95% confidence intervals, p-value less than 0.05 was considered significant. We did a univariate and multivariate analysis, and we adjusted for age, sex, BMI, diabetes, lung function, and CFTR mutation. So looking at our patient demographics, about 46% of our patients were on iron supplementation, with about 70% of them using it consistently per the EMR. The median age at the start of the study was 31 years. About 56% of patients had a homozygous deletion, CFTR mutation, and about 35% of patients had a heterozygous mutation. And then about 41% of our patients had pre-existing diabetes. So looking at the results for our primary outcome, for both the univariate and multivariate analysis, there was a significant increase in iron, ferritin, and percent saturation post-ETI, and there was an insignificant increase in transferrin. So looking at our secondary outcomes, like I said before, about 46% of our patients were on iron supplementation. So for patients on iron supplementation, so looking at the right side, there was a significant increase in iron, ferritin, and percent saturation within that group. And then there was an insignificant decrease in transferrin. Now looking at patients not under iron supplementation, so on the left side, you can see a significant increase in iron, transferrin, and percent saturation, and an insignificant increase in ferritin. Now, when we compared the two groups to each other, we could see there was no significantly higher increase in iron between groups. So alone, both groups had a significant increase in iron, but when you compared the two groups, there was no group that had a significantly higher increase. And then for the other lab values, patients under iron supplementation had a significantly higher ferritin and percent saturation levels. And then when comparing the no iron supplementation group with the iron supplementation group, transferrin was different. So it was, like I said before, insignificantly lower in the iron supplementation group. And then transferrin was significantly higher in the iron group without the supplementation. So now looking at our second secondary outcome. So these were patients who either took their supplementation as prescribed or took their iron not as prescribed. And so we can see for both groups, they had a statistically significant increase in iron. And so the group taking iron supplementation as prescribed did experience a larger increase in iron, but it was not different between the groups. So the difference was insignificant. And as you can see for the other lab values, when comparing both groups, there was also an insignificant difference. So in summary, ETI is associated with a significant increase in iron, ferritin, and percent saturation levels. Patients with and without iron supplementation had a significant increase in iron, and the difference in iron between these groups was not significant. So this suggests there was an increase in iron post-ETI, but it was unlikely due to iron supplementation alone. And patients taking iron supplementation as prescribed did not differ significantly from those who weren't taking it as prescribed in baseline iron, ferritin, percent saturation, or transferrin levels before or after ETI treatment. And those taking it inconsistently still had a similar increase in iron compared to those who were not taking it consistently. And for future direction, so this study does show the benefits of ETI on iron status in people living with cystic fibrosis. However, further translational studies are needed to understand the real impact of ETI on iron absorption and metabolism in people living with cystic fibrosis. I'd just like to give thanks to UVA School of Medicine, UVA Health System, my mentor and PI, Dr. Dana Alban, and the rest of my research group for helping me out. Thank you.
We do have a few questions from the app. The first is, did you collect data on PPI use in your subjects?
No, we did not. No.
Our next question is there a particular hypothesis in how ETI treatment could impact iron absorption or metabolism?
That's a good question. I wasn't able to really locate anything in the literature as to why it would be one over the other. We're thinking maybe it is increasing the just absorption and iron in the gut metabolism, but I couldn't find any specific studies that were telling us one way or the other. And like I said, future directions, I think that would be very beneficial moving forward to understand those biological mechanisms.
Did you have a way to adjust for possible infection or inflammation status with ferritin levels?
So we actually did an analysis later on after I submitted these slides, and we adjusted for MRSA colonization, Pseudomonas, and then also pancreatic insufficiency, and it didn't change the results at all.
The questions keep rolling in on the app. Did you look at patients' diet?
We did not, but that's actually a good question, something to consider for the future.
And were the patients on iron supplementation prescribed it before or after initiation of ETI?
So most of the patients were on, through chart review, most of the patients were on iron supplementation before ETI initiation.
Looks like we've got an in-person question.
Thought I'd mix it up a little bit. Dan Leung from Houston, really nice job. Congratulations. Was wondering if you could maybe educate us a little bit about the importance of iron deficiency in the CF population and whether or not it has a bearing on quality of life. That's my first question. My second question is, you did demonstrate that with or without iron supplementation, ETI appears to increase the levels of iron, ferritin, and PSAT. But maybe you could educate us that, maybe you could teach us whether or not these are clinically significant increases, because I can see the statistical increases, but I'm just curious if it really matters clinically. Thank you.
Yeah, of course. Thank you. So to answer your first question, a lot of the patients per the chart review, the reason they had iron studies done was because they were having a lot of fatigue, they were tired, they couldn't carry out their day-to-day activities. So I feel like this is really important to make sure our patients aren't iron deficient because, chronic fatigue is a real problem and it does disturb people's everyday their lives, day-to-day living. So I feel like this, is an important matter in our patients' lives. And then for your second question, yes, so the iron and ferritin increases were clinically relevant. I mean, you can see the increase was like 16.45 micrograms per deciliter and 23 for the iron supplementation group. Same for the primary outcome, the iron and ferritin were pretty clinically significant. The percent saturation was not clinically significant. The increase was statistically significant, but in reality, the change would not change what you would do clinically for a patient.
We have more.
Okay.
Did iron levels normalize on ETI?
That's a great question. For a lot of patients, it did. I don't have the infographic. There is a figure that we have that shows a lot of patients going from iron deficiency to like normal levels. And many of our patients did. I can't remember an exact number, but a lot of them did normalize.
And this question follows up on what you just mentioned is, do you have data on how many were able to come off of iron because of ETI?
I don't have the exact number with me. I'd have to calculate that. But we do know how many patients were able to normalize, so I can look back and tell that. But it was a decent amount.
Yeah, the next part of this question was clinical significant outcome beyond just an increase in iron numbers. Another one of our attendees wants to know, were any patients on IV iron supplementation?
Oh, yes. Not many, probably 3 or 4, but most of them were taking oral iron.
Iron compliance and outcomes are better, and those taking it every other day versus daily was looked at in this group on supplementation.
Yeah, so some patients were taking it daily, but most were taking it every other day or like a Monday, Wednesday, Friday type of thing.
Could you tell us how many of the patients were women in your subject group?
Oh, let's see. I do have that number, but not with me. I'm so sorry, I can't remember.
The follow-up to that was there a significant difference in clinical impact in female patients versus male?
No, so they were the same when we did the statistical analysis on a table that is not in this slide, unfortunately.
Let me refresh one more time.
Okay.
Let's see.
No more.
Okay, thank you.
Thank you so much, Amber. Okay, next we have Casey Wilburn also from University of Virginia, discussing the analysis of fat-soluble vitamin levels after initiation of ETI.
Hi, everyone. Thank you for having me here today. I'm going to go ahead and point out the elephant in the room. I did not follow the rules. I did not understand the assignment according to what the kids say nowadays. I just really want you to come see my poster, which looks very similar. So I want to thank Dr. Dana Albine, Dr. Lindsay Somerville, and Amber actually was also part of my abstract and manuscript for this. So a lot of our data will reflect one another. And I actually can answer one of her questions. We had 67 females in our study, which was 52% of the population. So it was pretty well split. So my particular abstract is on improvement of fat-soluble vitamin levels in cystic fibrosis patients after initiation of ETI therapy. So as we know, a lot of our information on ETI therapy thus far is related to lung function, sputum microbiome diversity, patient-reported respiratory symptoms, immune function, sweat chloride concentrations, and BMI. That led us to ask the question of, okay, well, we have pretty good solid data about this stuff. What about all of these other secondary complications that, we constantly worry about which also involves vitamin levels and fat-soluble vitamin levels specifically, as well as pancreatic sufficiency. So that's kind of what piqued our interest to this specifically. Another thing I'm specifically interested in, and I'm sure majority of us are, is the medication burden in our patients with CF. It's so prominent. It definitely leads to major issues with compliance and quality of life. So we really wanted to emphasize that in this study. We also wanted to talk about the fact that absorption and GI function in general has a huge impact on our vitamin levels and quality of life in general. So I'm sure all of you know and have similar experiences in regards to the amount of medication we're talking. We have some patients that take up to 25 pills a day. So 5 to 6, enzymes with their meals, and they may be on 2 CF-specific multivitamins and then have to also be on additional vitamin A, E, D. So it really does add up. So for this particular study, it was single-center retrospective cohort study. We had 128 adult patients with CF, and get demographic data included age, sex, BMI, CFTR mutation, and individual status of lung function, CF-related diabetes, and pancreatic sufficiency. So our median age was around 30. As I said previously, the sex was pretty across the board even. So pretty much 50% females, 50% males. And then BMI median was about 25. CFTR mutations were the F508 delta, and we had homozygous and heterozygous, which is exactly what was on Amber's presentation. And then we actually quantified the lung function for each of these patients and the severity of each, and quantified by that as well. And then we accounted for the CFRD patients as well as pancreatic sufficiency. So we collected data 2 years prior to ETI therapy and 2 years after retrospectively. We collected vitamin A levels, vitamin D levels, vitamin E levels, and then we used prothrombin time as a proxy for vitamin K to kind of get a gauge on that, since more frequently than not, we're not drawing vitamin K levels. We used linear mixed models to compare vitamin levels before and after ETI therapy. And then after we did that comparison, we stratified pancreatic sufficiency status as well to see what the difference between those two groups was. We did exclude patients if we didn't have good data pre and post ETI therapy, or if they had a solid organ transplant, which we did have a couple of in our group, which is great for them. So the final analysis included 125 patients. Vitamin A levels were estimated to increase by about 5 micrograms per deciliter after ETI initiation, which was statistically significant. Mean vitamin D levels increased by 0.4 nanograms per milliliter, which was not statistically significant. And then vitamin E levels increased by 0.631 micrograms per milliliter, which was also statistically significant. And then the log prothrombin time increased by 0.2026 log seconds, which was the equivalent of 2.6%, which was also statistically significant. I cannot get that out. So that was the comparison of all of the patients in general, not looking at pancreatic sufficiency. So this is where I think things get really interesting and go very well with our first presentation that was given. You can tell that all of the patients of ours that were pancreatic sufficient did not have any statistically significant changes in their vitamin levels, whereas the pancreatic insufficient group is the ones that saw significant changes in all levels except for vitamin D. I think it's really important to note that vitamin D may take a little bit longer of a time to show those effects. So it may be that a couple years from now we can look back on this again and see if that number has changed. And then, like I said, you can tell prothrombin time decreased pretty significantly, which is indicative of vitamin A increasing. I think a lot of us forget about what vitamin deficiencies actually mean, so I just wanted a quick reminder in our discussion. Vitamin A deficiency can lead to really negative, irreversible effects on vision, causing night blindness. I have one patient that always comes to mind, and every time I see her, it's getting worse and worse. And she's like, I just need to go see the ophthalmologist. And I'm like, let's also talk about your vitamin A levels. So I think that's really important to note in regards to quality of life as well. And then low vitamin D levels can cause decreased chronic lung function and bone demineralization. And like I said, we might need to look at this a little further in the future to get, some more data to see if it's stabilized or increased in the future. Vitamin E deficiency can cause defective nerve conduction and increase risk of developing anemia. Generally, that anemia is due to instability of hemoglobin membranes. And then low vitamin K can impair blood clotting and bone formation due to lack of osteocalcin production. This data further concludes the positive effects that ETI therapy may have on our nutritional parameters in people with CF. And I personally really hope that this can lead to decreased supplemental vitamins and enzymes. Unfortunately, I don't have the data now, but we are in the process of going through all 128 patients and seeing if we were able to actually decrease any of those vitamin supplements or enzymes. As we know, starting ETI therapy means a couple more pills. So being able to reason with patients and say, hey, we might be able to take away some, and what are the pros and cons of this trade-off, I think is really important. We do have some patients in our clinic who are still pretty hesitant about ETI therapy. I'm sure you all have some as well. The psychological effects that can happen tend to be a big barrier for our patient population. So I think it's important to talk about all the benefits of ETI therapy, also including, decreasing the amount of vitamins and enzymes that they may have to take. And that is it.
All right, we will start with some questions from our app. How long after initiation of ETI were the vitamin levels assessed?
So generally, I actually don't have the actual data for that, but in our clinic, if we make changes to supplementation, we generally draw levels every 3 months. Otherwise, we get them annually. So at a minimum, we have at least 2 levels post-ETI therapy. At a max, we could have 8. Sure.
Hi, Nicole from Seattle. Great talk. I was just wondering, did you see any supratherapeutic levels, say, for vitamin A when you were doing this study?
No, we did not. And that's something actually Dr. Albon and I have talked about looking into more, but we did not see any toxicities.
Okay.
Could increase in BMI, trending higher weight, could any of that have skewed the vitamin D levels to have seen less of a recovery?
I don't know. That's a great question. We've obviously seen quite a bit of weight gain in our group. Like I said, the median BMI was 25. We didn't have a ton of variation. I also think it's important to point out that our age groups varied anywhere from 18 to 65. So I think that'd be something that would be really interesting to look into.
Did any of your patients have liver disease? If so, did you look at their retinal binding protein to assess for vitamin A? Is this something we should do for all of our CF patients with liver disease?
Yeah, I think that's a great question as well. We did not. We just drew vitamin A levels in general. Our facility doesn't separate out. So I think that's something that somebody else could definitely build off of.
Another question came from, did you look at the diet?
We did not look at the diet. Clearly a common trend that would be interesting to look at in the future. We have a lot of retrospective data though, so I think we could go a lot of places with it.
They're rolling in again. Did you look at fecal elastase with increased vitamin levels?
Yeah, so we looked at fecal elastase as part of our criteria for pancreatic sufficient or insufficient. We also looked at patients' reported symptoms of steatorrhea. So those were the criteria that we used to determine pancreatic sufficient or not. We didn't necessarily trend the two together, though.
Mike Narquist, Colorado. This is actually a joint question from Dan Leung and myself sitting here. So, it's interesting to look at absolute numbers, but I think the real issue for clinical care is how many patients were deficient and improved into sufficiency, how many people were in borderline range, which we use for vitamin D, and not. So I think focusing on the increase, it says you get more absorption, but the clinically relevant data is did we change the number of individuals who are deficient? So I guess my question is, do you have that data?
I don't. I wish I did. No, I don't. As we collect the information about changes in enzyme therapy and their supplementation, I think that would be perfect to add in as well. I think that's a perfect point. Yeah. The data is important, but if it's not clinically applicable, then...
Well, you really do have the data, you just haven't analyzed it.
We have not analyzed it, but I have a great statistician, so perfect. I will call him when I get back.
Hi, Casey.
Hi.
I have a kind of a statement and just want to know your thoughts on this. So many of these vitamins, including our last speaker, the talk on iron, are influenced by acute phase reactants and are influenced by inflammation.
Yes.
And we know that post-ETI, we see an improvement in inflammation, lungs, gut. So I wonder what the impact of that versus actual total body levels of these vitamins is. And considering looking at CRP levels and how that changes too as the pre and post ETI.
Yeah, absolutely. That's a big part of the manuscript, actually. I go into quite a bit of detail about GI function in general and inflammation. Even though I think pancreatic sufficiency is really important, it doesn't paint the whole picture. So I do think it has a lot to do with inflammation as well and just changes in the GI tract. That's kind of why I wanted to add pancreatic sufficiency into this, because it's just one piece of the puzzle. And, it's true. Seeing the changes in vitamin levels isn't super helpful if we don't know what all is playing into that. So, yeah, I don't think we have any sort of inflammatory markers retrospectively on these patients. So that's probably a miss that we won't be able to add to the study.
Yeah, and I don't think it changes really our clinical approach. It's just an interesting question,
like
whether or not these vitamins are really impacted by the change in inflammatory status in the body versus actual absolute vitamin status. So thank you.
Yeah.
We do have a few more questions. We mentioned the pill burden that people with CF may have. And one of the questions is, with this vitamin level data after using ETI with vitamin levels in the normal limits, were you able to discontinue any of the CF specific vitamins?
So a lot of the discontinuations that we've had have been additional vitamins that we've had on top of like DECAs or just the general CF multivitamins. So, we have patients who are maybe taking 2 of those a day and then have to take an additional vitamin A to get them within normal ranges there. And we've been able to discontinue those additional supplements.
I just want to answer a couple of the questions. So in the multivariate analysis, I'm Dana Albon. I'm Casey's
Thank you, Dana.
mentor. So in the multivariate analysis, we included BMI, and we didn't see a difference based on the BMI in the levels. And then the other question was regarding inflammation. We measure the vitamin levels as outpatient when patients are, and I understand that the whole thing with chronic inflammation and maybe CRP levels chronically being elevated, but we measure the levels in clinic when patients are stable and not during exacerbations.
Another question was, do you have any other theories about why vitamin D levels were not significant?
We've had a lot of discussion about this. I think vitamin D is just very complex. We think about it from an endocrinology standpoint. I just think there's a lot more factors at play that maybe we are not privy to right now.
Wonder if the baseline levels might help there. If they were already sufficient to start, maybe you wouldn't see a change.
Yeah. No, that's a great point.
And we'll take one more question. Did you change any of the patients to the modulator specific vitamin supplementation?
No, a lot of them were just on what they were previously getting pre-ETI therapy. So it was pretty consistent. Try not to make a lot of changes if we don't have to, just because patient satisfaction wise, I feel like that can be a little difficult. So most of them are on the same thing.
Okay, thank you so much, Casey. Great job. Okay, next up we have Dr. Jennifer Duong from UCSF Benioff Children's Hospital, who she'll be talking about alterations in the fecal microbiota in patients with advanced CF-associated liver disease after 6 months of ETI.
All right, thank you everyone for joining me today, and thank you for the organizers for inviting me to this talk. So again, my name is Jennifer, and I'm excited to share with you alterations in the fecal microbiota in patients with advanced CF liver disease after 6 months of ETI. I have no relationships to disclose related to this presentation. As a pediatric gastroenterologist, I'm interested in the GI manifestations of cystic fibrosis, which contributes to significant morbidity and mortality. CF-associated liver disease, or CFLD, is the fourth leading cause of death and accounts for 2.6% of mortality for patients with cystic fibrosis. Furthermore, CFLD contributes to 0.2% of all liver transplants. CFLD is challenging to prevent and to treat. The reason for this has to do with a wide range of manifestations, ranging from steatosis, asymptomatic liver elevation, to more advanced forms of CFLD, inclusive of cirrhosis with and without portal hypertension and non-cirrhotic portal hypertension. Patients with CFLD are often asymptomatic, which makes it challenging to diagnose them early. And currently, we have limited treatment options to prevent the development and progression of advanced CFLD. Currently, the pathogenesis of CFLD remains speculative. In this first model, it's thought that defective CFTR function leads to focal biliary obstruction, leading then to hepatic inflammation, fibrosis, and disease. However, there's an alternate theory present that supports the gut-liver axis in advanced CFLD. In this model, it's thought that an imbalanced gut microbiota, or dysbiosis, leads to increased intestinal permeability, which in turn is thought to lead to the translocation of bacteria and their products into the portal circulation, into the liver, thus activating pathways of inflammation and fibrosis. Determining which of these models explains the pathogenesis of advanced CFLD is critical towards developing future therapies. Furthermore, we know that in patients with CF that a fecal dysbiosis has been shown. Part of this has to do with permutations in the CF GI tract that select for altered microbiota, including thickened mucus, abnormal pH, intestinal dysmotility, as well as antibiotic exposure and high-fat diet. This fecal dysbiosis is thought to lead to both gastrointestinal as well as extraintestinal manifestations, of which for today's talk we'll be focusing on liver disease and intestinal inflammation as measured by fecal calprotectin. Furthermore, we're at an exciting time with the advent of CFTR modulators, which we all know are powerful new therapies. And at least in the GI tract, modulator use has been shown to be associated with a decrease in fecal calprotectin. Thus, fecal calprotectin may serve as a useful clinical marker for responsiveness in the GI tract. So the purpose of this project has been to explore the link between intestinal inflammation, fecal dysbiosis, and advanced CF liver disease in the setting of CFTR modulator therapy with ETI. We hypothesized that the relative abundance of pro-inflammatory microbiota would be higher in those with advanced CF liver disease compared to those without, and that in patients with CF liver disease, the restoration of CFTR function with ETI would reduce the fecal abundances of pro-inflammatory pathogens, and that would correlate with a decrease in fecal calprotectin. Evaluating the effect of CFTR modulation may give us further insight into the role of CFTR in advanced CF liver disease, and furthermore may help us determine which model best explains its pathogenesis. To that end, I've utilized samples from the PROMISE study, which again is a prospective study evaluating the clinical effectiveness of ETI. And for this liver study, we are focusing on patients age 12 and older and looking at GI health and liver function. So for our study design, liver involvement was classified based on subjects' labs, exam findings, liver histology and imaging, and included subjects were those with advanced CF liver disease, as defined by non-cirrhotic portal hypertension and cirrhosis with and without portal hypertension, and then age-matched subjects with CF and no liver disease. Fecal samples were collected from subjects before and after ETI initiation at the following 3 time points. And at each of these time points, we measured fecal calprotectin and the microbiota. Calprotectin was defined via the ELISA immunoassay, and microbiota via shotgun metagenomic sequencing. For my results, I analyzed a total of 93 fecal samples corresponding to 34 subjects, 11 of whom had advanced CF liver disease and 23 who had CF without liver disease. I then made the following comparisons: the fecal microbiota among subjects with and without liver disease before treatment with ETI, and then the fecal microbiota among subjects with advanced liver disease at our 3 time points. My first observation was that the baseline fecal microbiota was highly variable between subjects. Shown here is a stacked bar plot with each of the colors representing a specific taxa, which is shown here at the class level. The x-axis represents our subjects. And what you can see is that for each subject, there is a varying set of color combinations, suggesting that there's a high degree of inter-subject variability. So we see that both in subjects without liver disease, as well as subjects with advanced CF liver disease. This is a fairly common finding in fecal microbiota studies, and it suggests to us that either a large effect size or a large sample size is needed to detect significant changes in the microbiota. I was then curious at looking at the baseline microbiota in subjects with and without liver disease, and I found some significant differences at the species level. I found that there was a statistically significant increase in the relative abundance of Streptococcus salivarius and Vianella parvula in patients with liver disease. So shown here is a box plot with the dark green indicating advanced CF liver disease and the olive green representing patients with CF without liver disease. The y-axis shows our relative abundance. And what you can see is that the dark green is higher compared to the olive for Strep salivarius. And the same is true for Vianella parvula. I was then interested in looking at the community level differences in the microbiota among our subjects with advanced CF liver disease. So shown here is a principal coordinates analysis, which is a graphical representation of similarity and dissimilarity in the microbiota. So the larger circles represent average microbiota and the smaller circles represent our individuals. And what we have found based on this is that at a community level, we did not find significant differences in patients with advanced CF liver disease between baseline 1 month and 6 months post-ETI. However, one thing I'd like to point out is that the smaller circles representing our individuals are dispersed throughout this plot, suggesting to us, again, that there's that high degree of intersubject variability that we discussed earlier. I was then curious, utilizing calprotectin as a marker of inflammation and of clinical responsiveness in the GI tract, would I see changes in the fecal microbiota in subjects who had advanced CF liver disease and a decrease in their calprotectin? So I found that of my 11 subjects with advanced CF liver disease, 8 of them had a decrease in calprotectin after 6 months of ETI. 4 of them had an initially abnormal calprotectin that normalized after 6 months, as shown by this line plot. And among the 4, I saw a statistically significant decrease in the relative abundance of Streptococcus salivarius and a trend towards decreasing relative abundance of Veillonella paruvula. I found these results to be really interesting because these 2 species seem to have repeatedly shown up throughout my analysis. And it's interesting because both of them have been shown to be potentially pathogenic. So going into further detail, Streptococcus salivarius, while typically regarded as a commensal organism, does have the ability to induce pro-inflammatory cytokine secretion and has been shown to be elevated in patients with non-CF cirrhosis and inflammatory bowel disease. Furthermore, there have been multiple case reports of bacteremia and spontaneous bacterial peritonitis with this organism implicated in patients with cirrhosis. Veillonella paruvula is pathogenic. It produces lipopolysaccharide and is also increased in patients with non-CF cirrhosis, primary sclerosing cholangitis, and ulcerative colitis. So overall, this work is supporting the link between intestinal inflammation, dysbiosis, and liver disease. So in conclusion, at baseline, I found statistically significant increase in the relative abundance of Strep salivarius and Veillonella paruvula in subjects with advanced CF liver disease compared to those without liver disease. That in subjects with liver disease, the fecal abundances of both species decreased after 6 months of ETI, and that correlated with normalization of fecal calprotectin. Again, both species have the ability to be pathogenic and have been shown to be elevated in patients with non-CF cirrhosis and inflammatory bowel disease. Overall, these results are supportive of my second model, which links dysbiosis to intestinal inflammation in CF liver disease, with an improvement in both inflammation and dysbiosis after ETI. Limitations of this study include lack of control for the effect of antibiotics, diet, and other treatment changes, and furthermore, this is a small sample size. I argue, though, that this is an evolving story and there's much more work to be done. So future directions include measurements of biomarkers of intestinal epithelial integrity, liver function, the fecal metabolome, and all of the above parameters at additional time points. So these are my acknowledgments. I would like to especially thank Drs. Nicole Green and Mike Narkowitz, whose interest in CF liver disease inspired this study. My research mentor, Dr. Luke Hoffman, as well as the other members of the Hoffman Lab, the PROMISE study PIs, as well as the patients and families enrolled in this study, our collaborators at the UW at the Sala Ponte Lab, and then the pediatric GI division at both Seattle Children's Hospital and UCSF. Now I'm happy to take questions.
Alan Smith from the UK. Thanks for a really nice and very clear presentation. I just want to ask you about the 2 organisms that you've singled out, the Veillonella and the Strep salivarius. Your shotgun sequencing looked for a lot of organisms, and this wasn't an a priori hypothesis. So do you think it's possible that those 2 organisms showed statistically significant differences in the group with liver disease by chance alone? Because you did look at a very large number. 1 in 20 is going to be significant by chance?
I think it certainly is possible. I did look at quite a few species, including, I did have some hypothesis in regards to some of the species. So I did look at E. coli, Staph aureus, Faecalibacterium, Ruminococcus, the both known pro-inflammatory as well as beneficial microbiota. So it certainly is possible. But I did think it was interesting that these species repeatedly shown up. What it means for liver disease, I'm not quite sure yet, but I definitely think it's interesting and important that they have shown up repeatedly.
Zach Seller, Stanford, Jen, very nice work. My question for you is about your cohorts in your CF no liver disease cohort. Is that truly that there is no liver involvement or fibrosis or anything, or is that they have no advanced liver disease, meaning cirrhosis and portal hypertension and so forth? Yeah, I guess the first ask.
Yeah, no, that's an excellent question. So yes, the way we defined our patients was based on histology, imaging, clinical exam findings. So the patients without liver disease really had no liver disease. So no liver abnormalities, no fibrosis, no other abnormalities.
Okay. If that's true.
I'm going to help her.
Okay. Maybe I have a follow-up question.
So Jen may not know because she didn't start and design the study, but so in PROMISE, liver was divided into 3 groups. So the CF, I think it's better to call it CF, no clinical evidence of liver disease. In that category, they had to have totally normal enzymes for the last 2 years. If they had imaging, it had to be normal. They had to have a normal physical exam and had to have normal platelets and other markers. So I think it's as good as we can get for that.
Okay. Yeah, that's helpful because one of the things I think that would be interesting to look at, and you may or may not have it, is actually those people that are pre-cirrhosis, right? That have some level or significant amount of fibrosis, but don't yet have multilobular cirrhosis and really sort of clinically advanced disease, to see if you can see any microbiota signatures that are sort of coming up and contributing to that pathogenesis, which is to sort of your last point. Is this really part of the cause of cirrhosis and advanced liver disease versus an association that it occurs in those that have cirrhosis? So.
Yeah, no, I think that's a great point. It would be interesting to be able to sort of track natural history and see if there's a certain biomarker that we could use via the fecal microbiome to see which patients are at increased risk for developing advanced forms of liver disease.
I've got a question. This is more for my curiosity. You mentioned biomarkers on your last slide, biomarkers that you want to measure. I think of gut barrier integrity. What biomarkers would those be?
There's quite a few that have been studied. So one that has been previously studied extensively before is the urinary lactulose to mannitol ratio. The only problem with this biomarker is that it usually takes hours to collect, and most patients don't want you to be collecting their urine. So that one might be not best in clinical practice, but others would be serum markers such as LPS binding protein, intestinal fatty acid binding protein. There's certain stool ones as well, zonulin, lactoferrin. Yeah.
Hi, Jade, University of Rochester. My question is about probiotic usage. Do you have any data about like which patients might have already been on this, and kind of like ideas for like usage and identifying patients who might kind of like benefit from that in the future?
Yeah, so specifically for this study, we don't have probiotic usage data recorded. The patients were part of the inclusion-exclusion criteria was that the patients were supposed to be clinically stable 14 days prior to enrollment of the studies with no changes in their medications. I think probiotic use would be really interesting. There have been other studies of probiotic use in other diseases. So certainly I think there could be a role in studying in CF liver disease, but I think there's just too much unknown right now about it.
Thank you.
Yeah.
We do have a question from the app. Did you account for patients with a history of small intestinal bacterial overgrowth, or SIBO?
We did not. Not that I know of in this study.
Okay, thank you very much.
All right, thank you.
And we are done. Thanks, everyone, for being a great audience. And thanks to all of our wonderful speakers. You all did a wonderful, great job.